Hi, I'm Dr. Martin Rutherford. I am a certified functional medicine practitioner, chiropractor since 1979.
Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractor.
So today we're going to talk about chronic Lyme disease. Is it an immune deficiency or autoimmune? And this is a topic that is I don't know if you want to call it a reply, a fill-in from last week. We did a topic on chronic Lyme disease last week. We discussed the fact that in the literature, but more so in our understanding of Lyme, it's an autoimmune problem. Let me just start out by saying we are not here to be controversial. We're not sitting here hawking our product. We do not, at the end of our presentation, say, and if you want to talk to us, just call here and do that. We do say, look at the references. We're not selling the Power Health autoimmune diet for people who have Lyme. We're not hawking our product of manganese that's going to cure everything. We're not Dr. Oz, who every day has to have some sort of a topic. Most of the time, he doesn't know what he's talking about because he doesn't have enough time to investigate it. I've been in practice since 1979. My interest in chronic pain started about 1987. And since then, we have interviewed 38,780 some patients. If you look at the top of the things, that's where we're at. Okay. Dr. Gates alone has probably reviewed over 6,000 to 7,000 peer-reviewed references, including all of the ones that were included in the sometimes caustic and sometimes demeaning replies to which we're going to answer here in a few minutes. So we're really not charging to do this. What we're doing is this. We started out with chronic pain a long time ago. And frankly, we really didn't know what we were doing. We had concepts. We had concepts that autoimmunity probably was involved. And we used a lot of the tests that we're going to talk about don't work today. We're probably going to talk about the fact that immune testing, you could say, is in its infancy, to the degree where I've had patients come in here with severe rheumatoid arthritis, redness in their metacarpal joints, what they call ulnar deviation, sitting in front of me and asking me if we could help them to calm down their immune system so that they didn't have to take the steroids, because the steroids can be very destructive over a long period of time. And I said, oh, so yeah, you have rheumatoid arthritis, huh? And they said, well, my doctor is not sure. The reason that they say that is because sometimes the antibodies for rheumatoid arthritis come up and sometimes they don't. Thus, the infancy in understanding of autoimmunity in the testing field, okay? A lot of the topics that were presented, the fact that if it were all autoimmune, we'd all be producing antibodies, that there's plenty of data on OspA, which, by the way, would lead us to believe that people maybe didn't listen to the entire production, because we talk about that and we actually agree with that person, and Dr. Gates may cover that. There are other answers than steroids. We just got done talking about that, but we don't sit here and hawk our answers. We're trying to let people know what the data is to the degree that we were just informed the other day that our data is being used at a professional school relative to some of the topics that we're covering in their classrooms because they're so well documented. Persistent infections, I think the quote was, "It's an infectious agent, you dope." I can deal with that. And yes, if you watched our videos, I was just informed that 85% of the time people pass an article on the internet from one person to the other and don't even read it. They just look at the topic and then they pass it on. And I'm also been informed that maybe people watch as much as maybe 5 or 7 or 8 minutes of the production and then they go on to it. And at the end, those people may not hear us say, go to powerhealthtalk.com, not to sign up, not to come to our miracle office, but to look at the thousands of references that have been attached to the however many articles that we've done since
How
we
many
started.
broadcasts? Yeah, exactly.
So many broadcasts we've done. So we're not here to like grind any axes, and we're not here to be controversial. We got into this to try to figure out why I was sick and why many of us were sick. That's why we got into it here. I had chronic disease, fibromyalgia, peripheral neuropathy, celiac. I had chronic fatigue. I have Epstein-Barr virus, for those of you who informed us about Epstein-Barr virus. I had parasites, I had H. pylori, and for those of you who think I'm kidding, I keep my file right on my desk so that when I'm doing interviews, I can show people all the testing. Full disclosure, I never bothered to test for Lyme because I am from New Jersey. I spent my entire lifetime picking ticks off of me when I was a kid. And in our observation of Lyme, we came to understand that it had some sort of an immune component when we saw our fibromyalgia patients doing very well, who had been diagnosed with Lyme, and we were not treating them for that, okay? So we're not here to, I mean, it's an observation. We are not researchers in essence that we are in labs doing research. Of these 6,000 to 7,000 research articles that Dr. Gates reviewed and more that I've looked at, okay, the research doesn't always agree. Frequently, it doesn't agree because the testing that they're using is at this point inconsistent and unreliable. So they have to draw conclusions. To take one research article and to pound it is a dangerous, dangerous thing to do, which is what several people have done here. Okay, we're going to address that to some degree. But when you've treated thousands and thousands of patients, you kind of have your own clinical lab going. And I said this to you even when you got here. And Dr. Gates has upped our game on that dramatically. And we see what works and we see what doesn't work. We're not pro-alternative or anti-medicine or vice versa. We are not, we know Lyme exists. We're not anti-Lyme. We don't think Lyme patients are crazy. I probably have Lyme. I should go get tested and see if I have it. I probably should do that.
The testing isn't really that accurate.
Well, we're going to get into that, but the testing isn't that accurate. But one of the patients says, well, if you get that test, it's only the rheumatoid arthritis knee patients that have it. And we'll address that too, okay? So we're going to address this. It's fine, and you can attack us some more, but don't attack us. It seems very difficult for us to embrace that the attacks came from people who listened to the entire broadcast. We will direct you to an article that we wrote. That's a 3-part article that was published here recently. It is voluminous. It literally, I mean, it's comprehensive would be a better word if you have questions. We would direct you to the research that Dr. Gates attached to all of our Lyme articles before you start throwing things at us that are clearly refuted or confirmed in the research. It would probably be a good idea to do that. Unless this is, I'm not an internet guy. I'm not even sure why I'm doing this. We're doing this because we're trying to share. And it's been greatly appreciated by a lot of folks and a lot of physicians and a lot of research places and schools and these types of things. Why am I going into this? Because the comments that came out there may be from people who are in Lyme groups, and we're trying to give you data that is real because it's worked in a clinical setting. Research setting, clinical setting, 2 completely different things. Things in the research don't necessarily work in the clinic, okay? And so you have to sift through those and find what's working. So that's kind of my layout there of like intro. What we're gonna do is we're gonna go again through, we're gonna tell the story of why autoimmunity is the problem versus a dysfunctional, low immune system that needs to be boosted.
And so going back to 2001, that's when kind of the landmark article came out. There was other speculation, so to speak, in the literature regarding Lyme disease being associated with an immune deficiency. But the article came from a gentleman by the name of Stricker. if I understand correctly, he's out of the Bay Area, out of Los Gatos. And he published this article basically saying that all these patients with chronic Lyme disease have a low immune system, specifically a low CD57 counts. And
which we used to use.
Which we used to use. And for those of you out there in the Lyme world, if you're seeing a Lyme literate doctor, you probably had a CD57 count run to see if you are immune deficient. And so Stricker had a pretty big population size of chronic Lyme disease patients. And he really came out and said, okay, this is what's happening with these individuals. Well, then his research findings were refuted by a researcher by the name of Marquez. And Marquez published their information out of Clinical Vaccine and Immunology, I believe, in 2009. And again, go to powerhealthtalk.com for today's references. And Marquez basically came in and did another study where they looked at let me make sure I have the nomenclature right, because frequently I'll refer to it a little differently. Post-Lyme disease syndrome. That's how they were referring to it. I call it post-Lyme disease symptoms. But post-Lyme disease syndrome, where they said, okay, these people had Lyme disease, they have these symptoms still after going through the antibiotics for 4-6 weeks, so on 2 to 6 weeks. And after having these antibiotics, these individuals still had these symptoms. And let's look at their natural killer cell counts. Natural killer cells are an immune cell that basically helps to fight bacteria and funguses and viruses to a certain degree. So they're there for the mono-a-mono combat killing of pathogens. And in Marquez's research study, they found no difference between immune cell counts of the natural killer cells comparing healthy controls to those suffering with post-Lyme disease syndrome. So that led Stricker to give a rebuttal because he was refuting their findings. And then ultimately in Marquez's rebuttal, it was an inflammatory exchange of words, if you want to say it that way, on both sides of the coin. But what Marquez pointed out was that in Stricker's study with chronic Lyme disease, they included patients in the study that may not have, and this is according to Marquez, so I'm just summarizing. So in Stricker's study, sorry, I got a little distracted. The dog is outside whining. That's the reality of our broadcast.
My dog is here. My wife's away for 2 weeks, so I have to take care of the dog. So the dog is outside.
The dog is a little needy.
So it's
right
not
now.
some person out there in pain.
We know that this is a serious broadcast. We're not meaning to laugh at the non-serious nature of this. So anyways, Marquez refuted that in Stricker's study, basically he included people who maybe didn't have documentation of an antecedent Lyme infection. So there perhaps wasn't documentation that a person actually had Lyme through a bullseye rash. They had immediate diagnosis relative to laboratory testing. Maybe they went through other laboratory testing that perhaps was not CDC verified. That's what Marquez was refuting. And Marquez went on to say that they did a follow-up study on these natural killer cells, and they found that in healthy controls, these natural killer cells will vary significantly from time to time. Which is a big problem.
Evaluating all of these immune tests.
Because we used to do these immune tests, and these immune tests, for those of you who have chronic Lyme, whatever nomenclature you want to put on it, you think you have had a Lyme infection and you're still having symptoms, these tests are very expensive. And they're called cytokine tests, they're natural killer cell tests. And the problem is with these immune tests is that these immune cells vacillate tremendously. So if you're going through an infection, natural killer cells may go up. Or if you're going through a massive killer cells may go down. And so that's the volatility of the issue.
And
that's
who's
why,
not going through stress who's getting tested for Lyme.
Exactly.
And these are the practicalities of understanding how to evaluate the data that you're seeing in these relatively inconsistent and possibly unreliable tests.
Exactly.
Because of that, the stress hormones can decrease natural killer cells.
So there's that component. And then in arthritis research therapies, I think 2014, it's attached to today's broadcast, they had a great study where they were looking at Lyme disease patients, and they looked at natural killer cells again. So they wanted their independent opinion. So now we get away from the argument between Stricker and Marquez, and now we're going to the argument proposed by some independent research team. And this research team looked at natural killer cell activity between people with Lyme disease who got antibiotics and felt better versus those with Lyme disease, got antibiotics, and didn't feel better.
This is important.
And they did see that those who got antibiotics and did not feel better had decreased quantities of one type of natural killer cell. So this is actually more in support of what Stricker was talking about. But then what they found is that the modulation of these natural killer cells, so the ones that were still present for the Lyme patients who still had symptoms, their natural killer cells were kind of uninhibited, and they produced a lot of inflammatory chemicals termed interferon gamma. So they had high levels of interferon, and this interferon, they stated in this research article, promotes basically unregulated immune responses in the joints, hence autoimmunity. And so that was a landmark finding, and that really supports what came out in the Journal of Autoimmunity in February 24th. I think the official publication date was March of this year that we talked about way back. I think it was like February 28th we talked about it, where they showed that people who have chronic Lyme-related symptoms, whatever you want to call it, post-Lyme syndrome, that they have antibodies to MMP10, as we talked about last week and we talked about then. So it's a certain type of enzyme in the joints that helps to clean up cartilage. And these Lyme patients were making antibodies to this enzyme. Right. So it's an immune dysregulation syndrome.
Even if they felt well, even if they took the antibiotics and they got well, they still, in a vast majority of the cases, were making antibodies to this MMP10 enzyme.
Right, and it was those who had the chronic Lyme symptoms had both a T cell and a B cell response to produce these antibodies, and that's why it was more significant. It was a more robust antibody response, immunological response for those with chronic Lyme disease, demonstrating that's autoimmune. Then last week we attached several articles again talking about signs of neurological autoimmunity in those who have chronic Lyme disease symptoms. We attach articles talking about OspA, which somebody commented on in last week's broadcast, and they were kind of refuting what we were saying. But really, what they were saying, they were agreeing with us if the research articles were actually looked at. And so that's kind of the story at this point. We appreciate the comments that were attached and some of the references that were attached by people that were rebutting our broadcast. They were looked at, and some of the stuff coming out of UC Davis by Baumgarth, he's basically saying that after you get a Lyme infection, there can maybe be a less robust antibody response for those who maybe have a chronic Lyme disease picture. And he was saying that that may predispose people to recurrent infections with it. We acknowledge that that can be true. And we're not saying that, again, going back to the whole argument between Stricker and Marquez and then the independent research group, they did show, this independent research group, that natural killer cells of certain varieties could be low in those who have chronic Lyme symptoms. But again, the ones that were still present were promoting basically an unbalanced immune response, an inflammatory response that could be associated with autoimmunity. So we agree with people to a certain extent that there may be an immune deficient component, but we also say you have to take one step further. And when you really look at the research, it's pointing to an imbalanced immune system, pointing to autoimmunity. That's where the new research is going.
Well, one of the big problems is research is research. I mean, you've gone through the classic eat salt, don't eat salt, do this, don't do that. You know, cigarettes are good, cigarettes are bad. Caffeine's good, caffeine's bad. A drink of alcohol is good. Now, just a couple weeks ago, came out in a research study that even one glass of alcohol a day is bad for you. So, I mean, we have this conflicting
It's so
research.
true. Aspirin's good, aspirin's bad.
All over the place.
No correlation between repetitive head injuries and problems later in life.
Exactly. So this is research. So as the clinician, here is what has to happen. If you even decide to try to pursue solutions for these things, and I say that because it's no small task, then you have to sift through the research. And it's not easy. Those tests ran into the thousands of dollars out of pocket.
Right.
It was like $4,500 out of pocket for the testing, just for the autoimmunity, just for the immune system. We don't, our testing today doesn't, I mean, what's it, $4,000, $5,000, $6,000, $7,000, or $100. Right. $400, $500, $600.
It's usually on the order of like $600 to $700.
$600 to $700. And that wasn't all the testing that was done, but we had to do it to understand that if we used the data from those tests, we had a lot of failed cases, okay? And we let people know that We were really just trying to figure this out, and we might have failed cases. We went through, what is the medical community saying? What is the Lyme literate doctor saying? How could entire groups of doctors be using technologies and having people not get well and have people keep going and going and going? There has to be some sort of a solution. So as a clinician, you keep going through the data. And then you're treating fibromyalgia patients and chronic fatigue patients. And one fibromyalgia patient and chronic fatigue patient hasn't been checked for Lyme or Epstein-Barr virus. Indeed, one of my colleagues here in Reno was one of the Lyme literate doctor, president of one of the Lyme associations, or the Lyme is that one that starts with
the alternative,
yeah, for years. And his position was all chronic pain is Lyme. Okay, I mean, we accepted that and we went with that, but we didn't find that to be true in our endeavors. We start getting a bunch of chronic fatigue patients. We start getting a bunch of fibromyalgia patients. They start improving, and we're not treating them for immune deficiency. These people are already coming in here, getting their immune systems boosted. And quite frankly, a lot of them were getting sicker. And so that was kind of a red flag to us. People who were coming in here and saying, these drugs are making me sick. These supplements are making me sick. My food is making me sick. These were all signs that there was an overactive immune response going on, either an allergic response or something along those lines. To those of you out there who, by the way, said, and apparently didn't read or watch the whole program, it's about herbs and botanicals and so on and so on. We use herbs and botanicals. We use diet. We use brain rehab exercises to calm down the brain so that the stress hormones that are throwing off a lot of these immune responses in the readings of these tests get calmed down so that we can have more accurate readings. So we use largely diet, botanicals, herbs, but there are times where a medication might be involved, but it's not a medication to suppress the immune system. And it's not a medication to boost the immune system. It's usually a medication ancillary to maybe some infection or maybe a thyroid problem or something along those lines.
What we're saying is we refer to physicians who use medications, and so.
Yeah, so we have found an integrated approach in a certain amount of patients, and not all, is valid. It's a persistent infection. Yeah, what do persistent infections do?
And throw off the immune system.
They throw off your immune system. What is your immune system trying to do to a persistent infection? It's trying to kill it 24 hours a day. And what does that mean? It means your immune system is flaring up. I mean, I don't, and I don't know what else to say other than we're just telling you what we see. There is a lot of stuff that we see that that we don't even bring up here, because we don't know how it would reflect as far as people thinking, oh my God, these guys think they know everything. We're just telling you what we see.
And we're telling you what the research shows.
And
too.
It's back, and what we see has been backed up by the research eventually. Eventually, sometimes we'll see things happen. For example, for a couple of years now, we would have MS patients come in. Mm-hmm. And frequently, by the time we got through with figuring out their gut and calming down what was going on in there and healing the leaky gut and figuring out what their food sensitivities are, there would be various degrees of improvement in that patient, almost without doing anything else. So what did that tell us? Something's going on in the gut with autoimmunity or directly MS. Past year, comes out, MS is coming from the gut, rheumatoid arthritis is coming from the gut. They think maybe lupus. Was it lupus or?
It's more RA, diabetes type 1, diabetes type 2.
And we've been
Sjogren's has an H. pylori component. Hashimoto's, everybody knows about that, connections to the gut. I mean, most of these autoimmune diseases basically have a gut connection and an infectious trigger mechanism. What we find, what we think is going on, is that the immune system becomes so dysregulated to the gut that it doesn't identify other infections as well. And we've attached articles on that. There's a Journal of Immunology article we attached to our diabetes broadcast 4 or 5, 6 weeks ago, where they were blown away by how dysregulated the immune system became when someone has gastrointestinal dysfunction in the form of this phenomena called leaky gut, which is a horrible term. We don't like the term, but that's what they were saying, and they're blown away. And then what we see, like with Epstein-Barr virus, for all of you out there who commented it's Epstein-Barr or have Epstein-Barr checked, we've done several broadcasts on Epstein-Barr, and really what it is that Epstein-Barr evades the immune system. And we even talk, and we think it's because, and basic literature is also supporting that in a circuitous route, that there's gastrointestinal dysfunction, the immune system becomes dysregulated. They're allowing these viruses to live. We talked about the persister aspect of Lyme disease back in our broadcast in February. We said how the Lyme disease can come in, it can come out. We don't disagree with everything from the alternative Lyme community. We don't disagree with everything from the infectious disease societies either. We just think it's probably somewhere in the middle, and we're trying to bring some truth to the matter, especially based on our observations, because we see a lot of people, I'll just say it simply, we see a lot of people who go to infectious disease doctors who are told that they don't have Lyme disease. And we know that the tests for Lyme disease and mainstream medicine, according to the CDC criteria, can have a lot of false negatives. So people may have Lyme and they get missed.
A lot.
And the CDC just came out a few years ago saying that Lyme was far more prevalent by orders of magnitude than they previously thought. But we also see a lot of patients who have these constellation of symptoms, from fatigue to widespread pain to brain fog, who are blown off by the medical community. The rheumatologists don't want to see them because they think they have fibromyalgia, so they go to a quote unquote Lyme literate doctor who then runs testing on them, which frankly the whole Lyme literate medical community agrees is not accurate.
Totally.
And then they say, oh, you have Lyme disease. And so then these people finally feel good that they get a diagnosis, but then they're taking another route where maybe they're told you need 6 years of antibiotics. And we're not saying that that doesn't work for some people, because we have seen that work.
Absolutely.
Although we've have seen quite a few patients where it hasn't really worked. And so that's where we want to say, okay, well, somebody needs to say something about this. And that's what we're doing. And we're giving you the new research. And frankly, the new research is building, and it's becoming more and more autoimmune, and it's pretty infallible at this point relative to the autoimmune model of Lyme disease.
Okay.
So that's the summary.
So that's it.
Yep.
So that's it on Lyme for us until some new data comes out. Before you attack us, and that's fine because I actually don't read the internet. He does. So you're attacking him. But before you do that, really watch all 3 of our broadcasts and look at the references, because every single, whatever you want to call it, whether they want to kind of comment or whether they want to call it an attack or whatever it is, some of them get a little caustic, is answered in there with firm data that supports the clinical approach of going after calming down the overactive immune system. I don't know what else to tell you. So that's it on Lyme for now. I'm sure there'll be more at some point in time when more data comes out. But until then, have at it. We hope that those of you who are looking for a solution enjoyed this. Those of you who are holding positions that frankly are positions that if you keep holding them are never going to get you where you want to be, which is better. Okay, you need to think about why you're doing that. So we're here, and we'll see you next week.
Okay, sounds good.